What if the symptom quietly ending lives right now, the one sending people to the ICU without warning, feels almost exactly like something you'd take a nap for? That's not a hypothetical. That's what's happening to thousands of people with Sjogren syndrome every single year in this country. And the terrifying part? Most of them had no idea they were in danger until it was too late to turn back. If you've been living with Sjogren's, or if you've been trying to figure out why your body keeps falling apart piece by piece, you probably know the symptoms everyone talks about. The dry eyes, the dry mouth, the brain fog, the nerve pain, the confusion that makes you feel like you're losing your mind. And here's what most people assume: patients, even some doctors, brain damage is the worst of it. The cognitive decline, the neuropathy, the thing that steals your memory and ability to function. That must be number one on the danger scale. Right? Wrong. Not even close. What the health Insyd analysis shows, when you look at mortality data, progression timelines, and misdiagnosis rates, is that the single most dangerous thing Sjogren's does to the human body is something most people don't feel until it's already at a critical stage. It mimics conditions that aren't considered emergencies. Doctors overlook it constantly. And by the time it shows up on a scan, the window for easy intervention may already be closing. We're going through the full ranking today. Every level. Every symptom. Building to number one, because understanding why it's number one could genuinely save your life. Most people miss this. You don't have to. If you're interested in this topic, type "interested" in the comments. And don't forget to subscribe. It only takes a second, but it helps the channel a lot. Let's start with why we are all confused in the first place. Sjogren syndrome, Sjogren's, is an autoimmune disease. Your immune system is the problem. Instead of attacking viruses and bacteria, it turns on the moisture-producing glands. The cells that make tears. The cells that make saliva. And over time, it goes far beyond that. The symptoms that get the most attention, in online communities, in Facebook groups, in magazine articles, are the neurological ones. Brain fog. Memory problems. Tingling in hands and feet. Shooting nerve pain. The feeling that your thoughts are moving through wet concrete. And those symptoms are real. Studies show between 20 and 70% of people with Sjogren's develop peripheral neuropathy, nerve damage causing numbness, burning, and progressive loss of sensation. There's also central nervous system involvement, where inflammation reaches the brain and affects cognition, balance, and mood. It makes complete sense that people are scared of the neurological piece. It's the visible piece. The piece you feel every single day. But here's the problem: it creates a blind spot. When patients are laser-focused on brain and nerve symptoms, they stop asking the right questions about everything else. When a doctor says your cognition looks stable, let's monitor the neuropathy, that feels like good news. You leave relieved. And you miss what's building in the background. This is called the distraction of the dominant complaint. The symptom that feels worse gets all the attention. The symptoms that feel subtle get filed under "we'll keep an eye on it." And "we'll keep an eye on it" with Sjogren's can be the most dangerous sentence you ever hear. Here's what makes Sjogren's uniquely dangerous: it is a systemic disease. That word is critical. It means the disease operates through your immune system, which touches everything. Your lungs. Your kidneys. Your liver. Your blood vessels. Your lymphatic system. The immune system doesn't send you a memo when it starts attacking a new organ. Sometimes the first sign something has gone seriously wrong is a blood test that doesn't match how you feel, or a scan result that shocks everyone in the room. So let's reframe. Instead of asking what's the most uncomfortable Sjogren symptom, we are asking, what is the most dangerous? What has the highest potential for irreversible harm? What kills? When you answer that honestly, the ranking is not what most people expect. If this is hitting you, don't just watch this and move on. Type "symptom map" in the comments right now, and we'll send you the exact breakdown we put into the guide. This is the same system people are using to track symptoms early before doctors catch it. And if you're serious about protecting yourself, the full book walks you step by step through what to test, what to say, and what most doctors miss. We are going from number 5, serious but manageable, to number 1, the silent killer most people never see coming. Not ranked by how bad they feel. Ranked by 3 criteria: mortality risk, speed of progression without treatment, and rate of misdiagnosis. Those 3 factors determine danger level. Not pain. Danger. Symptom number 5. Peripheral neuropathy. Peripheral neuropathy in Sjogren's is the nerve damage most patients eventually encounter. Burning feet at night. Numbness in the fingers. The sensation that part of your body has gone to sleep and won't wake up. What people think it is, a side effect of dryness, or simply aging. After 60, tingling hands and numb feet could be anything. Diabetes. Poor circulation. A pinched nerve. That's exactly the problem. When a 65-year-old woman tells her doctor her feet burn at night, the first tests she gets are for diabetes. If negative, maybe B12. If normal, maybe a spine X-ray. In a significant percentage of cases, nobody asks, has anyone tested this patient for Sjogren's? The average delay between Sjogren's symptom onset and diagnosis is about 7 years. During which time, neuropathy that could have been slowed is progressing unchecked. And it's not just burning feet. Autonomic neuropathy, where damage affects nerves controlling heart rate, blood pressure, and digestion, feels like dizziness when you stand too fast. Heart racing for no reason. Unpredictable bowel problems treated as IBS for years. It is not IBS. Treatment involves hydroxychloroquine, Plaquenil, one of the most commonly prescribed drugs for Sjogren's. In aggressive cases, intravenous immunoglobulin, IVIG. The key point: if the underlying autoimmune disease isn't treated, managing nerve pain alone is like mopping the floor while the faucet's still running. Peripheral neuropathy is serious. But it's number 5. This still isn't number 1. Symptom number 4, kidney involvement, the silent filter failure. Here's something that surprises almost every Sjogren's patient. This disease attacks the kidneys. Through tubulointerstitial nephritis, the immune system infiltrates kidney tissue and inflames the tubules, tiny structures that filter blood and regulate electrolyte balance. What does this feel like? Often, almost nothing. Increased thirst blends with dry mouth. Mild fatigue blends with everything else. Urination changes slightly. None of it alarming. And while all of that gets dismissed, the kidneys are losing function. Studies find kidney involvement in 5 to 35% of Sjogren's patients. That wide range tells you something. For decades, nobody was looking hard enough. The markers that catch this, creatinine, BUN, cystatin C, and urinalysis for protein, are standard tests but not always in a Sjogren's monitoring panel. A slightly elevated creatinine gets attributed to dehydration and nothing more. The real danger is renal tubular acidosis, where kidneys lose the ability to regulate the body's acid-base balance. This causes severe electrolyte problems, particularly with potassium. Low potassium, hypokalemia, disrupts heart rhythm. In severe cases, it triggers dangerous arrhythmias. This is how people end up in the hospital with what looks like a cardiac event, when Sjogren's has been quietly attacking the kidneys for years. This is number 4. 3 more to go. Symptom number 3, pulmonary involvement, when breathing becomes the problem. Breathe in right now. A normal breath. If that feels fine, good. But pay close attention, because this symptom looks like something far less serious for a very long time. Sjogren's attacks the lungs through interstitial lung disease, ILD. Inflammation and scarring develop in the tissue between the tiny air sacs. The interstitium. Early ILD feels like a dry cough. In a Sjogren's patient, that immediately gets attributed to the condition's dryness. Use a humidifier. Drink more water. And the interstitial lung disease keeps progressing. Next comes shortness of breath, subtle at first. Slight breathlessness climbing stairs. Getting winded faster on a walk. Nothing emergency room worthy. Inside, lung tissue is stiffening. Scarring is replacing functional tissue. Oxygen transfer becomes less efficient. Blood oxygen levels decline, slowly, gradually, and the body compensates. Until it can't. The tests that catch this, spirometry, diffusion capacity testing, high-resolution CT of the chest, aren't part of a typical annual physical. Unless a doctor has Sjogren's pulmonary involvement specifically on their radar, a slightly abnormal result gets attributed to age or past smoking history. The most common ILD types in Sjogren's are nonspecific interstitial pneumonia, NSIP, and lymphocytic interstitial pneumonia, LIP. LIP carries elevated risk of something we are returning to very shortly. Pulmonary arterial hypertension is another complication, rising pressure in the lungs' blood vessels putting dangerous strain on the right side of the heart. Lung complications are among the leading causes of serious, long-term harm in the Sjogren's population. This is number 3. Type scorecard in the comments if any of this sounds familiar, if your cough has been dismissed as dryness, if your breathing has quietly been changing. That's not something you watch and wait. We put everything into a step-by-step scorecard so you can track this properly and know exactly when to act. If you need it, it's there. Symptom number 2, vasculitis, when the immune system attacks the blood vessels. We are at number 2. This causes the most acute medical emergencies in Sjogren's patients. Vasculitis. Inflammation of the blood vessels. Every organ, every tissue depends on blood vessels for oxygen and nutrients. When those vessels become inflamed, when the immune system attacks their walls, consequences can be catastrophic, and fast. In Sjogren's, vasculitis most commonly affects small vessels in the skin, peripheral nerves, kidneys, and GI tract. It causes palpable purpura, raised, red or purple spots on the lower legs. Often the first visible sign. Often misdiagnosed as a drug reaction. But vasculitis doesn't stay small. Larger vessels become involved. Stroke, heart attack, bowel ischemia, where sections of intestine lose blood supply and die, and kidney failure. The cruel twist: Sjogren's patients who develop vasculitis already have significant fatigue and joint pain. New symptoms get absorbed into the same explanation. The leg rash gets attributed to poor circulation. Worsening fatigue gets filed under the Sjogren's acting up. Abdominal cramping is called gut involvement. Meanwhile, the blood vessels are inflamed. Blood tests that signal this: elevated ESR and CRP, cryoglobulins, abnormal proteins strongly associated with Sjogren's-related vasculitis, and complement levels, C3 and C4. Cryoglobulinemia alongside vasculitis signals a more aggressive disease course requiring urgent escalation. Treatment ranges from hydroxychloroquine for mild cutaneous vasculitis to corticosteroids and rituximab for severe involvement. Vasculitis is number 2 because it can kill acutely. Dramatically underrecognized. But still not number 1. What's number 1 is more dangerous because it doesn't announce itself the way vasculitis does. No rash. No acute event. It grows quietly for months, for years, until the options have changed. Before the number 1 reveal, 3 specific warning signals. When these appear in someone with Sjogren's, the disease is moving into more dangerous territory. Not symptoms to manage, signals that the intervention window may be shrinking. If any of these are happening to you right now, this is the most important section of this video. Warning signal number 1, unexplained weight loss without trying. A 68-year-old woman. 6 years of Sjogren's. Hydroxychloroquine. Regular rheumatology appointments. Functional, if not comfortable. Over 4 months, she loses 12 pounds. No dieting. Appetite slightly off, attributed to medication. She mentions it at her appointment. Doctor notes it, suggests more protein, orders standard blood work. 6 months later, they find what they missed. Unexplained weight loss in a Sjogren's patient is not a benign finding. It's a red flag, one of the warning signs associated with Sjogren's progressing toward lymphoma, malignant transformation of immune cells. The biological explanation: as Sjogren's progresses, the B cells chronically activated by the disease can begin proliferating abnormally. The immune system is working so relentlessly it starts consuming the body's own resources. Weight loss is a systemic sign of that metabolic demand. It mimics depression-related weight loss, thyroid dysfunction, anorexia from chronic illness and medication use. What it actually means: potential disease progression requiring immediate escalation, not wait and see. If someone with Sjogren's is losing weight without trying, even gradually, even just a few pounds over a few months, that needs an immediate conversation with a doctor who understands systemic autoimmune disease. Today, not next appointment. Warning signal number 2, swollen lymph nodes, especially persistent ones. Most Sjogren's patients know about swollen glands. The parotid glands on either side of the jaw can swell episodically. Most patients and doctors know this happens. But here's what gets missed: lymph nodes in the neck, armpits, or groin that are swollen and staying swollen. Not temporarily from a cold. Persistently enlarged, nodes that won't go down after a few weeks, feel rubbery, keep slowly growing. In the general population, A lymph node enlarged more than 4 to 6 weeks without obvious infection warrants investigation. In a Sjogren's patient, the threshold should be even lower. Why? Sjogren's is driven primarily by B lymphocytes, chronically and pathologically activated by the disease. They congregate in glands and lymph nodes. When that activation becomes truly malignant, when cells start replicating out of control, you have B-cell lymphoma. Sjogren's carries a significantly elevated risk of non-Hodgkin's lymphoma, specifically malt lymphoma, developing in glandular tissue the disease has been attacking for years. Research shows this risk is 5 to 44 times higher than in the general population. That is not a small number. And the lymph nodes are where transformation often first becomes visible. It mimics benign lymphadenopathy from chronic inflammation, sinus infections, dental infections. What it means: possible early lymphomatous transformation requiring biopsy to confirm or rule out. The workup includes PET scan, CT of chest and abdomen, LDH blood levels, which elevate when lymphoma is present, and lymph node biopsy. If you have Sjogren's and a lymph node has been swollen for more than a month, push for imaging. That conversation should not wait. Warning signal number 3, fatigue that is escalating, not staying the same. Fatigue is the single most universal complaint in Sjogren's. Expected. Almost a given. Which is exactly why it's the most dangerous warning signal to overlook. There is a critical difference between chronic Sjogren's fatigue, debilitating but stable, and fatigue that is escalating. Where a person who once managed daily activities with effort is now unable to get through a morning without lying down. Where it feels qualitatively different from what they've lived with for years. A 72-year-old man. For years of Sjogren's. Fatigue always significant. But over the past 2 or 3 months, different. Sleeping 10 hours, still exhausted. Morning walk stopped. His wife notices he looks pale. Gets winded faster than before. Next appointment, 6 weeks out. He waits. What may be building? Disease flare driving cytokine production, directly causing systemic fatigue. Anemia, autoimmune hemolytic or anemia of chronic disease, both caught by a CBC. Organ progression, kidneys or lungs losing functional capacity before dramatic symptoms appear. And the fourth possibility, the one nobody wants to consider, profound fatigue combined with night sweats and low-grade fever are called B symptoms. Associated with lymphoma. In a Sjogren's patient, that triad demands urgent investigation. Not a 6-week wait. It mimics depression, medication side effects, thyroid dysfunction, heart failure, sleep apnea. What it means: mandatory evaluation. Now, if your fatigue has shifted, if it's climbing, if it feels different, that needs blood work immediately, not at the next scheduled visit. We are almost at the reveal. Stay with this. Here we are. Everything built through this ranking leads to this. The number 1 most dangerous complication of Sjogren's syndrome. The one that kills silently. Definitively not brain damage. The one most patients and many doctors never see coming until it's significantly advanced. It is lymphoma. Specifically, non-Hodgkin's lymphoma arising from B-cell transformation in Sjogren's. Before you think I already knew cancer was serious, here is what makes this risk so uniquely hidden, and why it earns the number 1 position above everything else. The majority of people with Sjogren's will not develop lymphoma. But the data is unambiguous. Sjogren's patients have a risk of developing B-cell non-Hodgkin's lymphoma 5 to 44 times higher than the general population. Most well-conducted studies land in the 15 to 20 times range. The most common subtype is malt lymphoma, developing in mucosa-associated lymphoid tissue, the same tissue the disease has been attacking for years. 3 factors combined create a danger profile unlike any other Sjogren's complication. Factor 1. It develops silently from within the disease itself. Sjogren's doesn't cause lymphoma by accident. It creates the conditions for it. The chronic, unrelenting B-cell activation driving the autoimmune process is the same mechanism that, in some patients, tips into malignancy. The immune system has been in overdrive so long that the controls preventing abnormal cell proliferation begin to fail. The transition from severe autoimmune disease to early lymphoma can be completely invisible from the outside. No distinct crossing point. The symptoms continue looking like Sjogren's, until they don't. Factor 2. Early lymphoma mimics active Sjogren's almost perfectly. What does early B-cell lymphoma in a Sjogren's patient look like? It looks like a flare. Increased gland swelling. Worsening fatigue. Enlarged lymph nodes attributed to chronic immune activation. Elevated inflammatory markers, the same blood work profile an active Sjogren's patient generates routinely. LDH, lactate dehydrogenase, is one of the few markers that may signal lymphomatous transformation over immune activation alone. But it's not on every standard Sjogren's monitoring panel. A PET scan or CT might show abnormal lymph node activity, but unless someone orders that imaging with lymphoma specifically in mind, the order may never get placed. And so the lymphoma grows. Slowly, often. For months. Factor 3. The treatment window is not unlimited. Molt lymphoma caught at early, localized stage, confined to a single site like the parotid gland or a single lymph node region, is often very treatable. Some subtypes respond well to rituximab alone or local radiation. Outcomes at early stage are significantly better. Molt lymphoma that has transformed into diffuse large B-cell lymphoma requires intensive chemotherapy. Outcomes are less predictable. Treatment is harder. The difference between early and late detection can come down entirely to which symptoms got taken seriously, and when. Not every Sjogren's patient faces equal risk. Specific factors are associated with higher lymphoma development, and if you carry several of these, your monitoring protocol should be more aggressive. Risk factors include persistent parotid gland enlargement, consistently swollen, not just occasionally. Low C4 complement levels, indicating immune dysregulation linked to lymphoma development. Cryoglobulinemia, those abnormal proteins tied to vasculitis. Palpable purpura. A lymphocyte count trending down over time. And, connecting directly to the warning signals, unexplained weight loss. Persistently swollen lymph nodes. Escalating fatigue. The blood tests that should be part of Sjogren's lymphoma surveillance. LDH, beta-2 microglobulin, complement levels, C3 and C4, complete blood count with differential, serum protein electrophoresis, SPEP, and cryoglobulin levels. If those haven't been part of your routine monitoring, that is a conversation to initiate with your rheumatologist, at the next appointment, or sooner. The sentence that ties the entire ranking together. In its early stages, Sjogren's-related lymphoma does not feel like cancer. It feels like a bad month with the disease. Like the Sjogren's being difficult. Like the medication needing adjustment. Like a body that's tired and fighting, which is something it's been doing for years. There's no sharp pain signal saying, this is different. No sudden event triggering a scan. For many patients, it's caught not because something dramatic happened, but because a doctor ordered a particular test, or a patient pushed for imaging after recognizing a pattern. This is why vigilance matters. This is why knowing the warning signals matters. The window exists. But it requires action. Type symptom map in the comments right now if this is hitting home. If you've been told your symptoms are just the disease being active, if blood work came back slightly off and nobody followed up aggressively, if something has changed and you can't quite name what. We see you. Take this seriously. Let's pull everything together. This isn't about frightening you. It's about arming you. Those are two very different things. Number 5, peripheral neuropathy. Real, debilitating, progressive, but manageable when identified early and treated at the disease level. The danger is the 7-year average diagnostic delay. Number 4, kidney involvement. Silent, under-recognized, capable of triggering electrolyte imbalances that affect heart rhythm. Creatinine, urinalysis for protein, cystatin C, these belong in every Sjogren's monitoring panel. If yours isn't including them, ask why. Number 3, pulmonary involvement. The dry cough that becomes interstitial lung disease. The breathlessness that becomes reduced capacity. The tissue that scars irreversibly. Pulmonary function tests and high-resolution CT catch this early. They need to be used proactively. Number 2, vasculitis. Blood vessel inflammation capable of causing stroke, organ failure, acute cardiac events. Cryoglobulins and complement levels signal this risk. Requires aggressive, targeted treatment. Number 1, lymphoma. The silent escalation from autoimmune disease to malignancy. It looks like a flare. Feels like more of the same. The difference between early and late detection is the difference between manageable treatment and intensive chemotherapy. Every 6 to 12 months, Complete blood count with differential, comprehensive metabolic panel covering kidney and liver function, LDH, complement levels, C3 and C4, ESR, CRP, and urinalysis. At least annually, pulmonary function testing if there's any respiratory complaint. If lung involvement is suspected, high-resolution CT of the chest. When warning signals appear, LDH, beta-2 microglobulin, serum protein electrophoresis, cryoglobulin levels, and imaging. Know your own baseline. Know what your complement levels and LDH typically run, so when something shifts, you catch it. A value within normal range for the general population may be elevated relative to your personal baseline. That shift matters more than the reference range. Keep your own records. A personal file of lab results going back years is not paranoia. It is intelligent self-advocacy. One thread ran through every complication in this ranking. A symptom appeared, multiple explanations existed, and the less alarming one was chosen without ruling out the dangerous one. Interrupting that pattern requires specific questions that demand specific answers. Has kidney function been evaluated specifically in the context of tubulointerstitial nephritis? My cough has persisted for months. Has pulmonary involvement been specifically ruled out with imaging, not just attributed to airway dryness? My LDH and complement levels, what do they show today, and how do they compare to 12 months ago? I've read about lymphoma risk in Sjogren's. What is my personal risk profile, and what is our specific monitoring protocol for that? These are not the questions of a hypochondriac. These are the questions of a patient who understands their disease well enough to protect themselves within it. Hydroxychloroquine, Plaquenil, remains the foundation of Sjogren's management for mild to moderate disease. Manageable side effect profile, meaningful effect on immune dysregulation. But for patients with systemic involvement, it's often insufficient alone. Rituximab has become one of the most studied biologic options. As a B-cell depleting monoclonal antibody, it addresses the primary driver of the disease, and its relationship to lymphoma risk reduction is an active area of research. Used in practice for vasculitis, severe neuropathy, and cytopenias. Belimumab targets BAFF, B-cell activating factor, independently associated with lymphoma risk in Sjogren's, making it a biologically compelling target under active study. Clinical trials specifically studying Sjogren's progression and lymphoma prevention exist. For patients with multiple risk factors, asking a rheumatologist about trial eligibility is a conversation worth having. On supplements, omega-3 fatty acids have modest anti-inflammatory evidence. Vitamin D supplementation is relevant. Sjogren's patients are frequently deficient, and vitamin D carries immunomodulatory properties. But supplements are adjuncts. They do not replace disease-modifying treatment and do not address organ involvement. For every complication in this ranking, a window of opportunity exists. Early kidney involvement can often be stabilized. Early interstitial lung disease, caught before significant scarring, has more treatment options. Vasculitis treated aggressively at first identification can often be brought into remission. Early-stage malt lymphoma is dramatically more treatable than late-stage transformed disease. But the window requires that symptoms not be dismissed. It requires monitoring adequate for systemic autoimmune disease. It requires patients who know their disease well enough to recognize when something has genuinely changed. And it requires stopping the assumption that the most uncomfortable symptom is automatically the most dangerous one. Comfort and danger are not the same axis. You can be in serious, escalating danger while feeling, on a daily basis, not dramatically worse than you've felt for years. That is the single most important idea to carry out of today. We started with an unsettling question. What if the symptom quietly ending lives feels like something you'd take a nap for? Now you have the answer. The lymphoma risk in Sjogren's grows in the same biological soil as the disease itself. Through the same mechanisms driving the fatigue, the gland swelling, the immune dysregulation that has been attributed to your condition being active. For too many people, by the time anyone says lymphoma in a medical context, it has had significant time to develop in the shadows. The brain damage gets the attention. The nerve pain gets the support groups. The fog and the tremors get the clicks and the sympathy, and they deserve that, because they're real and they're hard. But the thing most likely on the chart of someone who died from Sjogren's complications is not brain damage. It's organ failure that progressed silently. It's lymphoma growing while everyone was focused on neuropathy. It's the number one on this ranking. And now you know what number one is. Here is the question that should be with you right now. When was the last time your Sjogren's workup specifically included the tests that would catch what we covered today? LDH. Complement levels. Imaging. A direct conversation about lymphoma risk and surveillance protocol? If the answer is never, or if you're not sure, you know what the next step is. You don't wait for it to feel worse. You don't wait for the dramatic symptom. You make the call. You have the conversation with a rheumatologist who understands systemic autoimmune disease. You ask the questions this ranking gave you. Early is a strategy. Delay is a gamble. The gap between them is exactly the knowledge this channel exists to give you. Type symptom map one more time in the comments if you're taking this seriously. If you're making that call. If something you heard today matched something you've been living with and dismissing. The ranking is real. The risk is real. And so is the window to do something about it. Don't wait for number one to introduce itself.